I feel inspired. Thank you, Retsef. And thank you, Ron. And thank you, Marty. Excuse me. We are very fortunate this morning to be able to have with us Dr. Elizabeth Baca, who will be delivering our keynote address. I met with Dr. Baca the first time this morning, and we chatted briefly about some of the things in which she's engaged. And it's broad, it's intriguing, and it's inspiring. So it fits right in with Retsef's closing comments. Dr. Baca is the Senior Healthcare Advisor in the California Governor's Office of Planning and Research. She provides leadership and direction for California's initiative to advance precision medicine. She is also engaged in multiple projects, including public-private partnerships, big data, and healthy planning, focused on elevating the connection between health and the built environment. And I hope she talks about that a little bit today, because that's a major challenge that we need to confront. She serves on the Committee for Community-Based Solutions to promote health equity in the United States at the National Academy of Sciences, Engineering, and Medicine. And those of us who are a little older will remember this as the Institute of Medicine. She trained as a pediatrician, and we're very fortunate to have her join us and give a, hopefully, and I'm sure, an inspiring presentation. So please welcome Elizabeth Baca, and hopefully she'll allocate a couple of minutes for some questions and even some answers. Thank you.
Thank you. Well, great. Well, I am super inspired this morning already. I wasn't actually going to talk a ton about the built environment, since I'm doing so much in this really highly innovative technological space of precision medicine. But it's really funny, and I think just really quickly, how many of you have been practicing physicians or have been on the healthcare provision side? Okay, so maybe like 20%, 30%. I think one of the realities is it always, when I actually did policy first, so I did policy before training in medicine, and then went through medical school, went through training, was actually teaching. It was at Stanford, and I used to teach about the social, economic, and environmental factors that impact health. And so you see really quickly, we can have all these discussions, but at the end of the day, it is so much about getting to behavior change, really understanding the context within which people live, where they work, where they play. And all of that, I think, is really the basis of how we think about innovation to truly impact change. The reason I ended up at the Governor's Office of Planning and Research was after spending a number of years providing care. I worked with kids specifically at a federally qualified health center in low-income populations, and you see really quickly that their life course is being set up to really fail them. And so I thought, we have this opportunity to do so much better, and it really starts with how we think about systems. So in the governor's office, when the governor became interested in precision medicine, it was really funny because I was doing a lot of this innovation systems change work at the population level, and they said, we've got this project. Can you staff this for us? Will you be able to help us with this? And I said, yes, this is where it actually fully comes together, and I'll tell you a little bit more about why I think that is. So it's really fun to be back in Boston as well. I did my training not too far from here over at the Kennedy School and down at the medical school, and I miss Boston. It's a great place. But one of the things, so I imagine most of you are familiar with the Federal Precision Medicine Initiative, and it's been fantastic. I remember driving in my car. I was listening to the State of the Union when President Obama announced precision medicine, and we, at the time, were doing a ton of work in this, so I was actually like, did I hear that correctly? But the governor actually announced his interest, or signaled his interest in precision medicine back in 2014. So this was actually a year before the federal initiative was launched. And he said in the State of the State, just as California has led the way with stem cell research, so too can we pioneer this new field of precision medicine. And it's really exciting as we started to talk about this. I think stem cell research was a much more clearly defined area to be working in. Precision medicine has actually been a little less defined because it is this paradigm shift. It's a newer way of thinking of things. So, it's interesting because some people you talk to and you say precision medicine, and the first thing they talk about is cancer and genomics, which is great because that's where a lot of these advances have been made. But just as we were just hearing about, it's also about your environment, right? It's really about patients. It's how do we engage patients in these processes? How do we design technology and things to meet them where they're at? Lifestyle, how can we use this technology to better capture their lifestyle, their behavior? So much of this, cost is another big one. So we can have a lot of innovation, but we also have to be thinking about cost. The reality is that we're spending so much on healthcare, and when you look across other countries and you compare us to peer countries, we don't have health outcomes that are actually matching that, despite the fact that we're spending so much. So this was, a lot of what is precision medicine? What is that going to be for us? So we actually, at the state level, have adopted a definition that I think is pretty encompassing, since there are so many different discussions and definitions that are out there. And I would say it's really grounded in data and how we think about the use of data. So we think of precision medicine as aiming to really use advanced computing tools and to be able to help us integrate and analyze and bring all of the data together to make it into knowledge, something that's actionable. And this is a range. So it's through research data, clinic data. When we think about the environmental health records, that's a huge opportunity of now that we are capturing a lot of this information. But having spent a number of years practicing on a lot of different EHRs, I always joke, I don't know if it was like a blessing or a curse that I've been part of rollout teams at so many places, but we have this resource that is not fully being leveraged. So again, it's really across these different types of data, and also population health settings. I think one of the things that's been really interesting is we read about the news that's going, how people are framing precision medicine, some of the articles and conversation that's come out in the New England Journal of Medicine and Health Affairs and JAMA. It's not about population health, and it's been actually really interesting. Some of the public health practitioners and folks have said, this is definitely not the way that we want to go. We don't want to be thinking about precision medicine. And I think that it's also, again, it really depends on that definition. So if you're thinking about how it can impact change at the population level, that's really, really key in prevention. So, it's really funny. One of the other things that comes up is people say, so does that mean that the care we're getting now is not precise? And it's kind of like a yes and no, right? So again, we just heard this morning, we think about randomized control trials, but we know that diseases, the same disease, will have a different outcome in different people. And so you'll see a range of how people respond to treatments. So a perfect example is diabetes and heart disease, right? So it really depends on all of these different factors. So what's your level of activity? What kinds of foods are you eating? What things are you exposed to? What is the underlying genetic condition? And then you kind of go through these different things over life, and you have slightly different outcomes. And so really, when we're thinking about precision medicine, it's more precise, but it's on prevention, diagnosis, and also on treatments. So shortly after the governor announced or signaled the interest in precision medicine back in 2014, we ended up getting an appropriation of $3 million. Now, one of the things is this is a very modest amount of funding. For taxpayer funds, $3 million is a lot of money. In the scheme of all of this is in research, I heard, what was it, $3 billion capital investment fund? I'm very jealous. That's great. But it was not a lot of money. However, the state is, the 6th largest economy. So we've actually had a lot in the world. We've had a lot of interest in how, California is starting to think about this and approach precision medicine. So with such a modest amount of funding, we actually wanted to make sure that we were really leveraging this funding. How could the state use this to really, advance precision medicine, advance the dialogue, the policy discussions? And we ended up spending about, I guess it would be around 6 months of having just a lot of thoughtful conversations with leaders. So we were talking with health systems, we were talking with providers, with academic institutions, patient advocacy groups, venture capitalists, entrepreneurs, really just across the board of what were some of the things California could be thinking about to really make an impact in this area. There were a number, there were so many things. These are just kind of, I think, the biggest things, but I think the one that came out most strongly, and that was heard this morning, is just for precision medicine to really succeed, it was going to take unprecedented levels of collaboration. Especially as we start to think about the data component of aggregating up. If you're doing great precision medicine within your institution and it's only looking at the data within your institution, you're not really capitalizing on all of the other discoveries and potential through aggregation and collaboration. So we heard a lot about that. Infrastructure and resources, there's a lot that exists currently, but it's not necessarily set up. I think electronic health records are an excellent example. There's a lot of potential, but they're not fully set up yet to leverage this approach for precision medicine. Multidisciplinary. This is one of the keys with precision medicine. Is it's in one of our projects, I'll mention it. It's actually one of the computational centers that got the funds, not a medical center. And I think that's really interesting. And I think that, thinking about MIT's leadership in this space, not being a medical institution, that is actually something that's really going to be key to think about. Patient engagement. So, having patients, I think that there's this paradigm shift happening around patients. They used to be on the other side, and now we're really starting to think about designing interventions really around them and user design. We also wanted to have patient impact within a short period of time. So this was something at the state level. We weren't thinking about early research that was going to be, 10 years from now. We wanted to have results and something that would be tangible for people in California to understand the benefit to them in a short amount of time. Various disease types of data we wanted to be able to bring into the projects. And then also not disease limited. So although there's been a tremendous amount of progress in cancer with precision medicine, different cancers have had different levels of progress, but it wasn't just about cancer. And we really also looked to the National Academy of Science report that came out in 2011 toward precision medicine. This was great. I don't know if you've read it. If you're interested in precision medicine, I highly recommend taking a look at that. But one of the things they recommended was doing smaller demonstration projects to be more nimble and to learn some of these lessons rather than undertaking something really large and then adjusting. So the way we set it up, so it's really hard to believe we just announced this in April of 2015. We've been working really quickly. We've got an amazing team that's working on this. So we ended up doing a partnership with UC Health with UCSF as the lead. And Tool Butte is the principal investigator who's been fantastic. Terry O'Brien, the vice chancellor. We actually have Keith Yamamoto, he was actually on the NAS board, and India Hook Bernard. It's just really a stellar team. Uta Grisheimer, who was used to be at the California Institute for Regenerative Medicine. So we partnered with them, and it was great to partner through the academic institution. We didn't want to do it through the state for a number of reasons, but we also recognize that it's not just about academia. This is also about private sector entrepreneurs, patient advocacy partners, and they were really great about being very intentional in bringing those partners in. We wanted to be able to leverage the funding and knowledge and also to position California to start to take a lead in precision medicine. So we ended up doing it there were two main components. One was through demonstration projects. We decided to do demonstration projects and then also to do an asset inventory. For the demonstration projects, it was really interesting. We ended up, for the first convening, and this was definitely not how these kinds of projects, if you've been part of the NIH and other things, we ended up bringing together all of the different stakeholders in precision medicine. Again, so all of the same people we were talking to, but we brought them together for two different convenings for the first call for proposals. And we set up the call for proposals specifically to highlight the importance of engaging across sectors. So bringing in private, bringing in nonprofit, bringing in patient advocate groups. We ended up just doing, since it was only $2.4 million that we were awarding for the demonstration projects in the first round, we ended up only limiting to UC institutions as a primary applicant, but said, hey, we want you to be bringing in other partners across the board. In the 6 finalists that we had over 40 partners coming in. And I think that really speaks to the level of really getting that collaboration and engagement incentivized. So I want to talk about 2 of our demonstration projects that are currently funded. The first one, again, didn't end up being selected in cancer. This is precision diagnosis of acute infectious disease. And it was really a new approach to use precision medicine in infectious disease. And as far as we know, I think this is the first kind of application at this scale for precision medicine in infectious disease. But we wanted to be able to leverage data and to improve diagnosis and care. So in traditional medicine, I think one of the things, if you've been a patient or if you've had a family member who's a patient or if you have practiced medicine, you recognize that unfortunately we don't have all the answers. And so, and when I was practicing as a physician, this would happen. We would get a really sick child. We would send the blood sample and the urine sample and the cerebrospinal fluid, and then you would look at the picture, you would look at the history, you would do all these things, and you would treat, saying, okay, well, this is what we think you have, but we've got all these tests pending, and then we're going to see what happens. And sometimes, 2 days later, all of your tests are coming back negative, and your cultures are coming back negative, and you still don't know what's happening, and the kid is getting sicker, right? And unfortunately, many times the tests work and we get an answer, but many times they don't. And sometimes it can take, days or months before you get an answer as to what the infectious agent is, and you end up retesting, and patients can get really sick, and sometimes you never get resolution. So with this project of precision diagnosis of acute infectious disease, essentially the sample is taken from the patient, and then is basically using next generation sequencing. They look at all of the genetic material in the sample. And through big data, computational analysis, through things that they had already been working on developing, they're able to pull out all of the human DNA and then look at a reference sample across everything else that's out there, and to be able to figure out what the infectious agent is. And this whole process right now is taking about 48 hours. One of the things about this demonstration project, and all of the demonstration project, again, when we were thinking about patient outcomes in a short period of time, more in the 2 to 5 year range, we wanted to look for things that had been scientifically proven, were very stellar projects, and were really at that cusp to have outcomes in a short period of time. So this is actually, this was written up in the New England Journal of Medicine on their technology. This was before the California Initiative to Advance Precision Medicine gave them funding, but this was work that was already happening at UCSF. These are images, brain images, and essentially it was this patient, I believe he was like 14, and he had traveled, and he started having headaches and malaise and all of these different symptoms, and kept going in to get clinically evaluated. He had 3 hospitalizations over 4 months, 44 days in the intensive care unit, and over 100 inconclusive tests. Now, obviously, this is a pretty significant case, but I think it just embodies how powerful, when we think about how we use data and technology. He was getting worse without any clear indication, and so they finally put him in an induced coma and did a brain biopsy. And at the same time, we're able to use the technology that they're using for this demonstration project, and he was diagnosed with neuroleptospirosis and then treated, and he's doing really well. And I can send more information if you're interested in hearing a little bit more about that case. The one thing before I move on that's really interesting about this project, and I think this is one of the lessons in precision medicine, is how do you end up working how do you integrate this into clinical care, right? So we have tumor boards, but for this project, they've actually set up an infectious disease consult team to start to think about how you interpret the genetic data to be able to use it clinically. The other program we have is the California Kids Cancer Comparison. So this is really about finding new leads for kids who fail traditional therapy. And in California, we have about 1,800 kids that get diagnosed with cancer each year, and around 400 or 500 of them fail traditional therapy. So they end up, some percent, maybe 100 to 150, end up getting recruited to go into clinical trials. Often the clinical trials are looking at the genetic information of the tumor cell to try and find new leads and reappropriate drugs. Only 10% of those kids really get a new lead. And so the goal of this project was, through leveraging all of this data that's already out there, that already exists, to try to figure out through genetic analysis where there might be some new leads through analysis of the data. And this is an example. So this project, this was the one I was mentioning, was actually awarded through UC Santa Cruz, which is fascinating because it's not one of our health centers, but they're collaborating with our health centers. So they're working with Stanford, with UCSF, with I think UC Davis, a lot of the different project partners. But they basically what they've done is they've created this data set of over 10,000 samples of RNA, and they're bringing in other data that's publicly available, all of these things that are out there for the genomic database. And they're essentially kind of, I always think when I look at this, I think of the LinkedIn maps, that they took away the LinkedIn maps, but if you ever saw them, it was kind of what are your connections? And so, when we classify tumors, we often think about the pathology of where the location is, and that's how we would do treatment. Well, we know now that because of genetic markers that tumor cells behave differently, even from the same location, or similarly from different locations. And so what they've been able to do is map out where the individual's tumor cell falls. And so basically, they've done this for about a little over 90 patients, and they've already been able to find new clinical leads. Now, it's too early to say, since it's only been about a year, how that's going to impact outcomes, but we're trying to get to a better place with treatment. This slide is out of date, so please don't tweet it. But we've actually brought in new partners, and some faculty have moved to other institutions, so we can, it's not completely up to date. But I wanted just to give you a snapshot of the types of partners who are participating on these projects. I think really strong is we have advocacy partners. They even gave money to one of the projects. They believe so strongly in this. And the other thing is we've been able to leverage matching funds. So we even had foundations come in with some matching funds for the project. We've definitely over doubled the initial investment by the state. The other piece is this ecosystem of precision medicine. So in California, we have a tremendous ecosystem from academic institutions to healthcare institutions to databases, different types of expertise and funding. And it's really interesting because as we look at what's out there, we often see that institutions are doing similar projects, a different component, but they're not talking to each other. And so a lot of it has been how do we start to leverage that at the California level. So really exciting, and we have the selection committee today in a couple of hours. But the state in the budget of 2016-2017 awarded an additional $10 million. So we went from $3 million to $10 million. So we actually are in the process of doing another competitive RFP. We're selecting new projects. But we just hosted this convening, again, bringing all of these partners together. And it's not the norm to be bringing such diverse groups together to be having conversations in this space. But I think it's really valuable because new ideas come out of this, new ways of collaborating and thinking about solutions. So this is, I'm giving you, these are the 10 finalists of the 29 projects that we got at the state level, and much of the stuff that's been talked about this morning already. So one of the projects is for personal mobile and contextual precision health. How do you start to take all these mobile devices and actually integrate them into the electronic health record? And how do you make decisions based on that? Another one is interactive web-based approach for outcomes and research with multiple sclerosis. So I think, again, we think about clinical care, and we have patients, they come in, they're there for a couple minutes, and then they go and they live their lives. And we know that there are very different outcomes for patients, and we don't completely understand all of those factors very well. And so this project would propose to be looking at all of that types of data, even including Fitbit data, for example. Prostate cancer, how do we start to think about the biologic variables and then predict response treatment? Despite the fact that it's a very common cause of morbidity and mortality for men, we still don't have as much information as we could. Also, just linking precision medicine data through the electronic health record, genome analysis of children for precision medicine for undiagnosed disease. This one's really interesting. Is that they want to use, for Dr. Mukherjee's project, artificial intelligence, right? So we have all of these tools, but how do we start to integrate them to create digital biomarkers for imaging, for neurologic emergencies, to be able to help in the clinical setting to make more rapid diagnosis and potentially to direct a physician, hey, this one's you got to prioritize looking at this scan when you've got 20 other scans you're looking at. So a whole host, and metabolic disease as well with diabetes. This was not planned, but one of the project is on early prediction of major adverse cardiovascular events using remote monitoring with biosensors, biomarketers, and patient-reported outcomes. So really interesting to be thinking about this innovation. And we actually had another one in multiple sclerosis. So really, it's going to be a tough job for the selection committee. They're all stellar projects. We're really excited to just see the breadth of projects that are being looked at. One of the other things that's been really interesting, and I was asking, I don't know if Massachusetts is thinking, we're the only state right now at the state level. I mean, there are tons of amazing institutions that are working in precision medicine, but the only concerted effort at the state. It's been fantastic since we've had the opportunity to work with the White House and the NIH and FDA to think about how we can leverage our resources in California. One of the other opportunities that came out was with Singularity University. So this is a benefit corporation based in Silicon Valley. They work with a lot of the big thinkers in Silicon Valley and entrepreneurs. And they came to us and said, hey, we would love to do a challenge. They do these impact challenges globally, but they wanted to do something in California. And so we thought this was a fun idea. And we did an impact challenge, which basically was really thinking about how can we leverage exponential growing technologies and think more about prevention, better management, and early detection. So we did this challenge with Singularity University, the Governor's Office of Business and Economic Development with their innovation hubs, and then our office, the Office of Planning and Research. And the winner got to present at Exponential Medicine. This was just a couple weeks ago, which was really fun. And you'll be very pleased to know that the winner is an MIT alum. We did not, I mean, this is one of the key things about precision medicine is it's not just about one state, right? The ideas can come from anywhere. So we actually had ideas globally. So people from the United Kingdom, people from South Korea. I mean, it was just really from everywhere that we got these tremendous ideas. One was actually another person who's based here in Boston was using artificial intelligence to look at spectral skin data and to basically try to detect melanoma earlier, right? So there are patterns and doing pattern recognition. So just a lot of really fun ideas to help us inform how we're thinking about innovation in this space. The other thing, so alignment with the national initiative, even though our initiative is vastly different than the national initiative, which is building this 1 million-person cohort, which it's great because I think that's building this larger research data piece. Ours is different, but it's complementary. So some of the funds went to Eric Topol down in San Diego. There's also a federally qualified health center that's going to be doing some recruiting. But recently, NIH announced a new round of funding for recruitment, and that will actually be with some of the UC health centers and Cedars-Sinai and some of the other California institutions, which I think is really important just because California is a very diverse state. And that's very reflective of where we're seeing the United States go as a nation. And I think particularly as we think about health disparities, making sure that we're really integrating patients that are reflective of the general population. And that's actually one of the big things. And even in our request for proposals for this round, we actually specifically ask about health disparities and cost-benefit analysis as well. But that's been an exciting development. So on the horizon, I think this is, we have the 10 million this year, which has been really exciting. And we actually are hoping to bring in, just as we did, we leveraged a lot of the funds from the first round to bring in non-state matching. We actually required that institutions put in funding to be part of these projects so that there was a real authentic partnership there. And we're hoping to really bring in a lot of those funds as well for this current round. The demonstration projects we'll have these two that have been underway for the last year, and we're going to be building up more with these next 6, and we'll see what comes next. But really the next year is going to be doing deep dive policy discussions. And so for instance, a great example of this is I was just with the FDA. I think one of the opportunities as the federal initiative is happening is thinking about how we even modernize the regulatory process, because policy can sometimes be challenging to get through, but very important. But as they think about mobile health technology, if we're starting to think about our cell phones as a diagnostic device, that's a completely different regulatory structure. How do we start to do that? And so being able to really host these deep dive discussions with our partners across the state of California. The last thing I was going to say is, this came up this morning. This is something that comes up a lot. We have a lot of different terms. So there's personalized medicine, there's precision medicine, precision public health. The White House actually just hosted a conference at UCSF with the Gates Foundation, and it was all about precision public health, thinking about population health and how that intersects, and then precision health. And I would say that all of those terms are, some of them have slight differences and nuances. The way that we've defined precision medicine at the state level, I think, encompasses all of those. there's a lot of promise, but it is really going to be about how do we take all of this data and make it into knowledge and something that's actionable. And I think it only happens through working together. So very excited to have conversations with everybody. And on that, I would say thank you. And it looks like we have 2 minutes for questions if there are any questions. If not, I will actually be, oh, we've got a question over that way.
The slide with the glioma with the colors, is that looking at California? Was that environmental factors?
With the glioma, which one? Let's see. This?
No, before, yeah, yes.
This one?
Yes.
So these.
I didn't understand that.
Yeah, so these, so not to get into detail, but every single dot is actually a different tumor. So they've mapped over 10,000 RNA samples. So this is from
subsets of gliomas in different areas. I don't understand what the different areas represent. Can you just explain it to me?
Sure, yeah. So there are 38 tissues and 28 sites. And so that one dot is that specific tumor and where it matches up compared to all of these other tens of thousands of tumors. And so that what they're saying is, like this one tiny dot here, we can pull it up and we can see all of the treatment information that they got, how it behaved, what it was resistant to, how it responded to treatment. So what they're doing is taking that one individual tumor that gets sequenced, and they're looking across all of these tens of thousands of tumors to see what things might be applicable to provide therapy. Yes.
Interesting contrast. Professor Levy talked about how proud he was that MIT doesn't have a medical school, and that's how they could contribute. Your group of sponsors, your sponsor page there, showed one company that wasn't a medical institution. To what extent do you think precision medicine will come from outside the healthcare industry, from data analytics or something that is completely unrelated to what we view as healthcare today?
Yeah, no, I mean, it's a great question, and a lot. I think it's going to be a lot. I mean, Oracle has been really interested in what's happening, working with them on some stuff right now. They're not necessarily a health institution. DNA Nexus, SciOps, those have been technology solutions, and they're actually partner projects as well. So I think it's really going to be, you have to have both coming together. One of the things that's really interesting specifically in the digital health space, I don't know if any of you have gone to Health 2.0. It's a great conference. They have a lot of innovations. What happens is, my observation is you have a lot of parallel tracks of innovation, right? So it's like, we're going to come up with this app, we're going to come up with this solution, this digital health product, and it's completely separated from what happens in the clinic. And so what happens is you have these things running, and it's like then the physician's not benefiting from that. The patient's doing some of their own management. It's not really being leveraged. And so I think that what we need to do is bring things together to really make it actionable. But I think definitely it will be also outside of the healthcare industry for sure. And learning some of the lessons that have happened in other industries, I think is going to be really important. Yes. Oh, no more. I'm getting the sign no. I'm sorry. But I'm unfortunately miss some of the day because we are selecting the other projects. But I will be here in the afternoon and would love questions, discussion, and to learn more about what you're doing out here in precision medicine. So,
Elizabeth,
thank you.
That was terrific. Thank you so much.